Clinicians have powerful new tools that can help diagnose MS earlier. And the sooner the disease can be diagnosed, the sooner patients can begin treatment that can prevent further damage.
These tools reduce the previous need for what's known as watchful waiting, which is looking for new symptoms to emerge over time. We're now joined by Dr. Michael Dwyer, a main researcher in this new study, and Dr. David Honacki, a neurologist who treats patients at UBMD Neurology. You've seen some of their work here recently on News 4. Gentlemen, thank you so much for being here. This is very good news for our population because, as we know, our Jackie Walker has been a part with MS locally for years, and we see those populations on the rise locally. So let's talk about how we diagnose earlier. How is it being done?
So when someone comes in with their first episode of multiple sclerosis, it can be optic neuritis. And now the new criteria allows us to look at the nerve of the eye on special techniques and use that as one thing that we can apply. Sometimes people come in with what's called transverse myelitis or numbness, weakness, incoordination, and we can look at the spinal cord as well. And then when we think about the newer techniques with the brain, if we see lesions or abnormalities on the MRI, we can start to look at some of our special techniques, and I'll let Dr. Dwyer talk about that for a minute, such as a central vein sign. You see the vein through a lesion, or a paramagnetic rim lesion.
All right, yeah.
Let's talk about what that is.
What is that?
Well, so one of the big problems that clinicians like Dr. Honacki face is when someone comes in, you see these lesions on the brain, but it's not 100% sure that it's multiple sclerosis. It's just something going wrong in the brain, and a lot of times it's MS, but it's not necessarily. And so there's been a big search for some kind of signal that would say, yes, this is an MS lesion. It's not something else. MS is often called the great mimic because it can create symptoms of many other diseases depending on where the lesion is. So some really amazing researchers at NIH actually first discovered these paramagnetic rim lesions, and we've been investigating them for about a decade now. And basically, they're these lesions that have a very specific signature for MS. This kind of rim of what's called microglia. It's cells that actually start to. They're normally very good cells in your brain.
Sure.
They help out. They clean things up. They're kind of like the police of the brain, but they kind of go bad in MS. These microglia, and they start actually smoldering and growing these lesions in a very bad, damaging way, but they're also very specific to MS. So if you see these, you have a much better idea that somebody has MS.
Let's talk about the timing of this. Prior to this kind of a finding, how long would it take someone who came into your practice with some of these symptoms to be diagnosed versus now you have new markers? So what are we talking about in terms of the differences of time?
You could probably look at months to years sooner. And so now you can say to someone, we've looked at your MRI, we've looked at the newer criteria, and based on how you came in and based on how your MRI looks, we say that you have MS.
How important is years of a person when they have an MS diagnosis, when you're talking about that time period?
We always say when you diagnose early and treat early, you absolutely can change the outcome of this condition.
Yeah, absolutely. Let's talk about the treatments, too, over the years. They have gotten so much better. I've been to Walk MS. I've heard Jackie say it. Over the past decade, even, it's gotten so much better, I guess the best word. Talk about those treatments.
Yeah, so right now, I won't talk about individual ones because there are so many, but we now say that we have almost 30 medications. And each person presents differently, and each person is unique in terms of what they accept as risk and what we know as benefit. Differences in terms of side effects. Back in the days of when Larry Jacobs, led to the first MS treatment here in Buffalo, we've gone so far. And back then, if someone couldn't tolerate that one class of medication, that's all they had to offer them. Now we have dozens of medications to offer to the patient to stop their condition, that disease, early on.
One of the problems, though, is so these these treatments do a really great job now of stopping these new lesions from forming in the brain. And for a long time, we kind of thought that MS was the immune system from the rest of your body attacking your brain. And it is. It's called the peripheral immune system. It comes in from outside, gets into your brain, and creates these lesions. But what we understand now is that there's also kind of these resident cells in the brain that do their own thing. They're part of the brain's own defense system. And they're seeming to go bad too with these paramagnetic rim lesions. We also have what are called slowly enlarging lesions. And what's still unsolved is these lesions still drive disability progression in MS, even though they stop what's called relapses that maybe Dr. Honacki can explain. So it stops these attacks, but it doesn't stop a kind of insidious progression of disease. Don't get me wrong, though;
Sure.
they're amazing. They do a great job, but we still are not at a cure yet.
So a lot of words being used there, a lot of sort of keywords I'm hearing you say that are related to these studies and what the future could be. If someone is at home and they're watching this and maybe they are thinking about symptoms and maybe they're thinking within their own mind, hey, I'm starting to notice some different things, what should they start talking to their doctor about, or when? And if they perhaps have already talked to their doctor about an MS diagnosis, is there new information that they should be bringing up, or should their doctor already know about this?
I think most physicians who do MS in neurology already are up to date on the information, but as a patient, you should always discuss your symptoms and how you're doing with your medication. You should have repeat MRIs at time periods to make sure that your MRI is stable as well. So we think about clinical stability, MRI stability, but absolutely you talk to your doctor, you discuss everything, and then they will decide with you, is this the medicine for me? Do I need to be on something else? And as Dr. Dwyer said, we have a long way to go to figure this out in terms of stopping progression.
And Dr. Dwyer, UB will continue to do that research, I assume.
Oh, absolutely, yeah. I mean, there are still a lot of challenges unsolved. One of even the challenges with these new criteria is not all MRI machines are capable of doing them right now. So this is new. It came from the research world and was incorporated internationally into the criteria, but it doesn't work on every single MRI. So we need to research tools so that everybody can have access to these new diagnostic tools, and that itself is a big challenge.
Every time we hear from the folks at UBMD, it is always groundbreaking, it is always new, and it is always life-saving. Gentlemen, thank you so much for being here. Thank you for your work in this field. Clearly, it affects many, many people in this region, so thank you for it.
Thank you
so
for
much.
having us.
Thank you for having us.